Good afternoon, everybody. And thanks for persevering on this Friday afternoon. So, lifelong imaging follow-up. Again, like Dermot said, as clear the guidelines are for sports and activities, they are just about as clear for advanced imaging. I have no financial disclosures. As they say, love may or may not be forever. It may or may not last forever, but your aortopathy stays with you forever. So you definitely need a plan for follow-up. If you are a patient with a documented aorta, you may or may not have a dissection. What is your plan if you have an aortic aneurysm? What is your plan for dissection follow-up? And what is your plan if you had surgery or endovascular stent grafting? And then you have to deal with family members and what recommendations you need to give them. So obviously, let's tackle the patients that you have identified an aortic aneurysm. The echocardiography remains the first-line diagnostic modality. We don't need to go around radiating everybody and their grandmother. But there are issues with echocardiography. Those of us who do multimodality imaging, including echocardiography, we recognize that echo it has many challenges. If your aortic root or your aorta is eccentric, you are gonna overcall, undercall, you're gonna be wrong. If you have, then there's errors in measurements. There are all these Z-scores, A, B, C, D, Z-scores that have been developed, but these are based on echocardiography. So if you do not know where the error in measurement is, the material going into building these data sets, your results can vary. And essentially, you have to be very cognizant about using echocardiography for serial follow-up as well as precise quantification. CMR, especially a lot of these patients are going to be younger, and you will need frequent imaging, serial imaging. So CT may or may not be the best option. Although I will say in 2019, a lot of CT techniques of the radiation dose have gotten much, much lower to a point where radiation is not going to kill them. Having said that, CMR, especially for serial follow-up, has a distinct role. It can also assess branch involvements, LV size function. If you have concomitant aortic valve disease, then you can take a look at it. Also, if your etiology happens to be arthritis or some inflammatory conditions, then CMR is clearly the way to go. Again, as I alluded to yesterday, you do not have to give contrast to get good images. There are techniques available where we can do a quick CMR without starting an IV, essentially. So, things to keep in mind, especially when you're doing serial follow-up. And again, as I had mentioned yesterday, gated contrast CT angiography is basically the gold standard. Keyword, again, cannot emphasize more, gated, especially if you're dealing with ascending aortic pathology, you do need to gate your scans. For descending and stent graft, et cetera, you may get away without gating, but clearly anything north of the diaphragm, you do need gating. And ways to measure, again, I think it is important to emphasize because too many times we see these measurements done wrong. Axial measurements are not appropriate as they are often reported in radiology. You have to use 3D software to do precise measurements because millimeter to millimeter, you are making very important decisions based on these things. Garbage in, garbage out. Too much is dependent upon all these patients. We are making hardcore decisions about sending them for surgery based on these measurements and cannot underscore the importance of comparing prior images to assess serial growth. So, area or diameter. Diameter is one way of looking at it. Often you're going to have eccentric roots, eccentric dilated aortas, and as has been talked about yesterday, careful what you're getting in terms of a number. especially in the root. It's a 5 centimeter aortic root. How was it measured? Sinus to commissure, sinus to sinus, this, that, what we do, we routinely report in our CAT scans and CMRs is an area. And then the clinician can assess the area to height ratio and figure out what the cutoffs, et cetera. But we have a couple of papers in trileaflet aortic valve as well as bicuspid aortopathy where we have shown that the area to height ratio is a much better predictor of longer term outcomes in at least our population compared to the diameter. And most people can attest to the fact that there are advantages of looking at area over diameter. So a hugely busy slide. And this is a compilation of ACC, ESC, and ASE recommendations. Basically, bottom line is if your aorta is less than 5 centimeters and you do not have a documented familial aortopathy, then you do annual follow-up. But if your aorta grows by 0.5 centimeters per year, then 6 monthly and start planning for surgery, involve the surgeon early. In Marfan's, again, the size threshold is much lower at between 4, 4.5, and clearly you have to ascertain that they are not growing fast. BAV remains a little bit controversial, and especially in a center like ours, we are a little bit more aggressive in sending the patients earlier than the recommended 5.5 centimeter threshold, especially if we index their area to height, and if they happen to be in the intermediate range with good outcomes or good expected outcomes, then we have no problem sending them in earlier than a 5.5 centimeter threshold. Same needs to be said on this Turner syndrome. You have to index them to something because these patients tend to be shorter. Lois Dietz, again, a little bit more aggressive, even more aggressive than Marfan's, and there's no clear recommendations on Ehlers-Danlos syndromes. So the other aspect is follow-up after aortic surgery. In my opinion, CT is the mainstay. We occasionally use CMR, but the precision that you get on contrast-enhanced CT is better than any other modality. But you have to know what the operation was to be able to give a good, coherent report. It's not a one-size-fits-all report. If you have a valve-sparing root, you have to know the valve, you have to know the coronary osteal patency, and you have to look for a leak. If it's a supracoronary graft, don't have to worry about coronaries. If it's a Bentall, similar to a valve-sparing root, you have to also look at the coronaries. If it's a frozen elephant trunk, ascending aorta, depending upon what the surgery has been, you have to tailor your report. In a frozen elephant trunk, you have to also, along with the anastomotic leak, you have to talk about endoleak. And then if you are lucky enough on a Friday afternoon to end up with a crazy case like this, you have to go through the trouble of identifying what the heck did Roselli do to your patient. But this happens to be ascending to visceral bypass or other traditional debranching bypasses. Stent grafting, triple phase CT scan is necessary, native, arterial, and delayed post-contrast. And these are, I'm not a vascular surgeon, so I'm not going to talk about the different types of endoleak. Suffice to say, if you have a stent graft, you need to be very diligent in looking for endoleaks. These are a couple of examples. This is a patient with an endovascular stent graft who has a type 2 endoleak, basically from a intercostal branch that has not been occluded. This is somebody who had a ruptured aorta. I think I showed this case yesterday, and patient underwent endovascular stent graft and walked out alive from the hospital. So follow-up times is important. Again, in my opinion, if you have an aortic dissection, pre-discharge 1 month, 6 months, and yearly CT, I'm not a big fan of doing CMRs for these follow-ups unless it is later downstream. Acute intramural hematoma, same thing. Chronic dissection, again, pre-discharge 1 year. Here, most of us do annual evaluations, but these are some of the recommendations. Stent graft it's CT and X-ray to make sure the stent has not migrated and there is no endo leak. Family screening, I do not believe there are any firm recommendations. Certainly everyone needs to go see a geneticist if you suspect syndromic aneurysm. Imaging screening of all first-degree relatives, I do not believe echo is appropriate. Everybody, in my opinion, I at least do one tomographic baseline scan, and depending upon what the deal is, then progress beyond. Frequency, I don't know. If they're totally negative, then you can call it a day, or maybe repeat it 3 to 5 years. There are no firm guidelines. What do I do? As I said, do echo and at least one baseline tomographic scan. Depending upon their age, it could be either an MRA, or a CT scan. So this is a lifelong disease and requires meticulous planning. Plan needs to be nuanced and tailored to a given disease state and a given surgical procedure. As I've said before, every aorta deserves world-class imaging. Thank you.